Okay. My name is Laura Ettinger, and I am happy to welcome Dr. Nanette Wenger back to the Oral History Project run by the Women in Medicine Legacy Foundation. The foundation interviews the Alma Dea Morani MD Renaissance Woman Award winners, and Dr. Wenger is the 2023 winner of that award. So I am delighted to be picking up where we left off at our last interview session. Our interview today is taking place on Monday, December 22nd, 2025, with Dr. Wenger at her office at Grady Memorial Hospital in Atlanta and me at my office at Clarkson University in Potsdam, New York. So, Dr. Wenger, I want to return to your pioneering work in women's cardiovascular health. At the end of our last interview, you explained that you had always been taught that heart disease was a man's problem. But you were, at Grady, you were seeing women at the clinic who had heart problems, and you went to the scientific literature, you said, and you found nothing about women and heart disease, that all the studies involve men. So you pushed to change this. And I want to dive much more deeply into your push. It sounds like you had to push over and over again to study women's cardiovascular health. So if we can start with, what were the early obstacles to getting the field to recognize the importance of studying cardiovascular disease in women?
Well, the background to this is that I was seeing patients in my clinic. I was seeing women who had heart disease, who had chest pain, who'd had a heart attack. I was seeing women hospitalized, first in the hospital and then subsequently in the coronary care unit. But when I went to the literature to say, how do I treat these women, there were no data. I consulted my colleagues at the Emory University School of Medicine, who uniformly said, well, there's no difference. And that was the assumption. And no one was ready to query whether that was correct. We were beginning to get tests and drugs to treat heart disease. This was almost the renaissance of cardiac care for coronary disease. But all of the studies were studies in men. We were beginning to address preventive interventions, things like the Coronary Drug Project. Again, all men. So trying to find some data, and there was nothing in the literature or in the standard textbooks. I went to the American Heart Association, who told me that it was not a problem. The American College of Cardiology, who said we have the data for men and did not see women as a problem, and then went to the National Institutes of Health. And early on, it was the National Heart Institute. Later on, it became the Heart and Lung Institute. Blood hadn't been added yet, and again, went to them, who said that was really not a priority area. Well, it was a priority for me. And I continued to write to the various people in charge of the groups. And I think finally someone listened. And in the early 1980s, developed a workshop that it was my privilege to lead with two colleagues. And it was an exciting workshop. And, typically the time between a workshop and a conference is 2, possibly 3 years. This was 6 years before the conference evolved. And again, it was my privilege to chair that conference with Doctors Leon Spiroff and Barbara Packard. And the conference essentially followed the format of the workshop, defining what was known about women and particularly coronary heart disease, but some about other heart disease, and most importantly, to outline the knowledge gaps. It culminated in a manuscript that was published in the New England Journal of Medicine in the late 1980s. And at that time, the editor of the New England Journal said to me, I believe this is the first time that a manuscript that links coronary disease and women in the title has been published in a major journal. And it did increase interest. Again, the New England Journal has powerful influence on the clinical and the research community. And many research scientists in the basic sciences and the clinical sciences looked at the knowledge gaps and began to work. Someone quoted to me a quote of Emerson, and I don't know if I've said that to you before.
You did, yeah.
But this is really what it is. I've gone on a trail, and what has happened in this trail that I walked is that it became an information highway. I enrolled a large number of research scientists from many, many areas in my vision, and each of them took off in a direction, and we began to get data. But this really early on involved only the people who saw this as an interest of theirs because they were either women or because there were women in their lives or because there were women in their laboratories. But it did spread, and we began to see data emerging about women. And as the data emerged, the differences became evident. Years ago, the biggest medical meetings for cardiologists were the American Heart Association and the American College of Cardiology. And when I look back at the programs for those meetings, looking at the index to say, was there anything that said women or pregnancy or hormones or anything that might touch this area, there were no entries. And beginning in the 1990s, that emerged. With that, we saw a number of groups of people emerging with particular interests. The Women in Cardiology group, both within the American Heart Association and the American College of Cardiology. And obviously, as women in cardiology, we had particular interest in our women patients. But this was not solely, although predominantly, an effort of women. There were very many men involved in this search. And we began to get data. And to summarize it very briefly, there were emerging data that showed that the women responded differently to physiologic, sociologic, psychologic, socioeconomic challenges. And there were differences between women and men in the basic physiology, in the pathophysiology, epidemiology, preventive interventions, diagnostic tests, clinical outcomes, long-term therapy, and that was both for medical therapy and for the emerging interventional therapies, surgical and medical. So we began to see differences. And there was an effort to say, do we report these? What is the necessity for reporting them? And for a number of years, there was a consensus among the journal editors of the prominent cardiology journals to urge, not to require, but to urge the journal editors for clinical trials, to report separately the data for women and for men, or to say there were no differences. What we tried to do, and the only place we really could have influence, were within the governmental agencies. And over the years, the National Heart Institute, National Heart, Lung, and Blood Institute suggested that the studies reported out of NIH report the data, both the basic science and the clinical science, differently for women and for men. And that was when some interesting information emerged. And that was that the basic scientists often did not know the provenance of their cells or tissues, meaning that potentially they were studying women's diseases in tissues from male animals or cells from male animals, and that often even the animal studies did not report whether the animals were male and female. And as most people who've done lab work realize, male animals are cheaper than female animals, at least in the rat population and mice population. And likely the studies were being done on male animals. Over the years, the urging became more prominent, and in one of the revitalization acts for NHLBI, there was the requirement that the sex of the animals, tissues, cells, etc., be reported. Very recently, there was, for the NIH, a requirement for the plan for a submitted request for a clinical trial. And that was really population-based, to say if you were studying a population, let's say just studying the differences between men and women, that your research plan had to include what you would do at a certain point in your recruitment if you didn't meet your recruitment goals. If you said you were going to recruit 50% women and your recruitment was 20%, what were you going to do? How could you pause the recruitment of men? And what was your plan to recruit more women? And if that wasn't present, the trial could not even go through the committee. Now, in 2025, I'm not sure how that is being applied, because is that called DEI? What are we doing not just for men and for women, but for subgroups of women? Because women are not a homogeneous population. And there are huge differences between Caucasian women and women of racial and ethnic minorities. And the women of racial and ethnic minorities are particularly underrepresented in clinical studies. So we will see how that application happens. There was a recommendation within the Food and Drug Administration. You know, if I have a drug or if I have a device and I go to the FDA with a planned clinical trial, and I say, FDA, if I do this clinical trial in this way and I have significant results, are you likely to approve this? And FDA looks at it and helps say, will you approve it? Well, there were recommendations, but not legislation, that said there should be a representative population for the group that would use the drug or the device. And if women are half of the population, obviously there should be half of the women in the trials. And over the years, there were recommendations to industry, and recommendations can be followed or not depending on your bent. And the bent was usually not, because it was a challenge to recruit women. And only very recently was the requirement imposed that if the drug or device was to be licensed for a representative population, that that population had to be represented in the trial. So now, or recently, the FDA would say to industry, if you want us to broadly apply this, you have to have that population. And there was some interest in the issue of the aged. That didn't go as far, but many of the geriatric organizations were saying if a population over age 80 is not in the trial, perhaps this should only be licensed for people under age 80. That didn't go anywhere. But again, the question is, what is the application of all of these recommendations and regulations under the new administration. Is this considered DEI? If it is, it's not going to be applied. But representative populations represent good science, and good science is the basis of good medicine.
Uh, this is all fascinating. Thank you so much. I have so many follow-up questions. I'm trying to decide where to begin. Um, Maybe I'll begin with this. Why do you think others weren't seeing what you were seeing? It sounds like it took until the late 1980s, right, to have this workshop, this National Heart, Lung, and Blood Institute workshop, which then led to the conference, which then led to the publication of the your groundbreaking article in the New England Journal of Medicine that talked about cardiovascular health and disease in women. Um, so, but you were recognizing this stuff back, it sounds like in the late 50s, early 60s, right? When you first came to Grady and
It
saw
was, it was 60s and 70s.
60s and 70s. Okay. So why so much resistance?
Well, we learned, and all of our senior colleagues learned, that heart disease was a man's disease. And the assumption was that if the prototype individual, which is a 60-kilogram white male, responded this way, that the whole world would respond that way. There was never a question of doing things different for pediatric patients. And pediatric patients were always studied separately. But no one really thought about geriatric patients and that they might have to be studied differently. And if men were considered the model, women were supposed to follow suit. And it took a long time and accumulating data, and particularly data showing that women had worse outcomes than men for all coronary events and for all coronary interventions. And even as we started to look at medications, one of the interesting questions that arose is women being over-medicated? In most drug trials, women have more adverse events. Now, is it that women are reporting more or that they really have more adverse events?
Mm.
But if we look at the drugs that were removed from clinical use by the FDA for serious adverse events, they predominated in women. And very recently, someone looked at a trial of heart failure medications. Now, this wasn't a good research study, because the research study is designed prospectively. This was not. This was a retrospective look at a heart failure trial, looking at the patients who took half of the recommended doses of the medicine. And the women did just as well with half of the dose and didn't do better with full dose. The men did not do as well with half of the dose and did better with the full dose. Again, not good science, but enough science to suggest that there are differences, and perhaps we have to do dose ranging studies in women.
Interesting. And how recent was that study?
Last few years.
Okay. Okay.
It's a retrospective look at a clinical trial that was done.
Okay. And going back to the National Heart, Lung, and Blood Institute workshop, which led to the conference, which led to the publication in the New England Journal of Medicine, you said it took 6 years from the workshop to the conference, which you said was very unusual. What did you have to do to push in that intervening time, and how did you do it?
Well, there were people who were involved in the workshop, and obviously people who were involved in the workshop had some skin in the game. This was an area of interest for them. For many of them, it was Dr. Spiroff, who was an OBGYN, much of it was the interest in hormones. I think my interest was less in the hormone aspect, although it was obviously important, than it was in the other medical and interventional part. But we just continued to say, where is the workshop, to try to get it onto the calendar. And if I think something is important and I think that I can contribute, I guess I have almost a bulldog mentality, and I continue with it. If it is important, and I think it is an important contribution to medicine, I'm just very, very, very aggressive about this,
You,
and
you,
get my colleagues to join me. And it's not really fighting a system; it's getting an entrenched system to move a little bit at a time.
so you mentioned last time the bulldog analogy, and now you're saying that, right, it's getting an entrenched system to move a bit at a time. That sounds like that requires an awful lot of patience. Um, I guess, how have you remained patient when there has been so much evidence, right? And there was so much evidence that women's cardiovascular health and disease needed to be studied differently and treated differently.
Well, I had so much else that I was doing. I was involved in a number of clinical trials, many of them exclusively in men. I was
Mhm.
doing a lot of medical writing. I was seeing patients, and I was looking at a number of things. I was still pretty actively involved in cardiac rehabilitation and in some of the rehabilitation efforts, but I thought this was important. And as a matter of fact, during that time, I edited a book on heart disease in women with a co editor from the United Kingdom. Actually, the book went into two editions. And I was doing things in the area and doing a number of studies so that I just had to keep coming back to this again and again and again. And I think I've discussed with you that my leadership style is very different from most, that most people who are leaders lead top down. My leadership style is bottom up. So all that I think that I have to do is to enroll people in my vision and then let them take that vision of studying heart disease in women and do it in their individual way.
Yeah.
And this is how the field expanded, so that people were looking at many, many aspects of heart disease in women. And some of that actually continues until today. If we look at cardiology, there are the standard areas of subspecialty in cardiology that are established at SOLA. But the two new areas that are growing very, very rapidly address women or predominantly women, and that is cardio-obstetrics, because we are seeing a disastrous maternal mortality in the US, higher than in any other industrialized nation, and cardio-oncology. It certainly involves both men and women, but one of the major challenges is breast cancer and its therapy. Breast cancer, the second most common cancer in women, second only to lung cancer. But we have so many fantastic breast cancer drugs that women aren't dying from breast cancer anymore. They're dying with their breast cancer. But the sad thing is when I see a woman in my clinic and I say, congratulations, your breast cancer is cured, but you now have heart failure as a result of some of the radiation and chemotherapies that cured that breast cancer. So that the cardio-oncology, because the oncology is having such unprecedented success, that is a very rapidly growing area.
And it sounds like you're saying that you, through your leadership style, have helped to encourage a lot of people to explore all these different areas within cardiology, like cardio-obstetrics and
Yes, yes.
cardio-oncology. Yeah. Okay. Um, so, um, again, so many interesting things that you've said. Again, going back to the early 90s when this publication came out and the conference had taken place, um, how controversial were your conclusions?
I'm not sure they were controversial. I expect they were unanticipated because there was such substantial differences in so many areas between women and men. But the good clinician, looking back at the patients that he or she had treated, realized that the women were not doing as well as the men.
Yeah.
That after myocardial infarction, after coronary bypass surgery, after percutaneous interventions, women were not doing as well. They were having more complications with the
Yeah.
procedure. Their outcomes were not as good. Their bleeding complications were greater. And it was not just in the coronary area, it was in the stroke area. And looking at the stroke registries, they saw that a smaller percentage of women with an acute stroke were transported to the hospital by EMS. There was a longer period of time before the diagnostic study, and then much longer period of time before any of the new exciting thrombolytic and other interventional therapies. So why was anybody surprised that the stroke registry showed that more women than men died within 40 days of a stroke hospitalization? We saw that in so many other areas, that with peripheral arterial disease, which was once thought to be a man's disease and now seems slightly more prominent in women, that fewer women were treated with guideline-directed medical therapy, and fewer of the appropriate women received interventions. Uh, we saw with heart failure that typically when the pumping function, when the ejection fraction is reduced below a certain point, a defibrillator is recommended. Why is it that fewer women than men receive defibrillators? Is it the woman, or is it the provider, or is it the interaction between the two? And for many, many other areas, there are comparable differences. And importantly, the differences have not diminished over time. That's really the concern that we have.
So, yeah, I want to ask some questions about that too. Maybe I should ask a question that's quite basic, but what are the symptoms of heart disease that women in particular should be paying attention to? Yeah.
Well, there was an excellent scientific publication on chest pain that came out a few years ago, and very important because with heart attack, that is often the initial presentation of coronary disease in men, no warning. In many, many women, they have chest pain before their heart attack, which means you have the opportunity to avert that myocardial infarction. Excuse me. But what we've seen is that chest pain was often ignored in women, and particularly so in younger women. And they were told it wasn't their heart. And of course, women are, as I've said many times, adjective adverb people, and men are noun verb people. The man will say, I have chest pain. The woman will say, I have pressure, heaviness, sudden shortness of breath, and I have pain that goes into my neck, jaw, shoulders, back, abdomen. And sometimes the multiplicity of symptoms that women often report obscure the component of something going on in the chest, so that very many women are underdiagnosed, so that they do not realize that their symptoms related to their heart until they have some major event, an acute coronary syndrome.
Okay. Okay. Um, and what would you say are misconceptions about women and heart disease today that remain most dangerous?
Again, I think the misperception that heart disease is a disease of old ladies. There is a very interesting study on women who present with an acute coronary syndrome to the emergency room. And for women over age 65, and the 65 was arbitrary because it was the Medicare population.
Right.
Women in the Medicare age group are looked at as promptly and sent to the cath lab as promptly as are men. Younger women, here defined as below age 65, had a longer time than men before their first EKG, their first troponin, the recognition of an acute coronary syndrome, and the trip to the cardiac catheterization laboratory. And as we know, time is muscle. So if women go later to the catheterization laboratory, it should not be surprising that they may not do as well.
And to what extent do you think public awareness has changed around some of the kinds of things you're talking about with regard to women's cardiovascular disease?
Well, you know, in the early 2000s, and I think it began about 2004, there were two major public education efforts: the National Heart, Lung, and Blood Institute's Heart Truth campaign and the American Heart Association's Go Red for Women. So much so that now the red dress is the accepted symbol of heart disease in women. And the purpose of the campaigns was to teach women that the female heart is vulnerable to heart disease, and to teach them how to respond to symptoms of a heart attack, and to teach them about their heart health and the things that were necessary for heart health. Now, what happened is that by about, I think 2009, when we published the first report, there was an increase in awareness from about 32% to the mid 50s. I think it was 56%. And we reported, this was great. Look at this increase in awareness. It's almost doubled. Mm-hmm. Well, I viewed that as a glass half full, because if only 56% of women were aware, almost half of women were not. And we should have persisted in those education campaigns, but we didn't. But when we look back in 2019, looking at the same representative populations, we found that we had lost almost all of the gains over the next 10 years, and that most of the women did not recognize the symptoms of a heart attack, and that lack of recognition was highest among the most vulnerable population, younger women and women of racial and ethnic minorities. So we now have 10 years worth of catch up to do, catching up to something that is really not optimal, so that education is really of the utmost importance, because if women do not perceive themselves to be at risk, they will not heed any preventive interventions. But we have today an important tool that we didn't have in the year 2000. We have social media. And social media now give us an opportunity to reach so many of these vulnerable populations if we can get public influencers to propose that message. And this has been done actually in some of our South American neighbors. The women in cardiology in Latin America have put together a program addressing maternal mortality. And what they've done in most of the Latin American countries is to have one day that was called Bump Day, for the bump of pregnancy. Now it has a much more elaborate Spanish name. But on that day, there is widespread public education about the importance of coming heart healthy to a pregnancy, the importance of coronary risk factors. You go to any shopping mall that day, and there are educational materials for women about heart health. There are screening tests. All of the stars of sports, stage, screen, radio are sending messages there. And in a number of the countries, they have worked with governments so that there is some government funding for the screening and for the educational programs. In Argentina, that day is legislated into action, and there is government funding for some of this. So, so many of the things that we've done in the Heart Association over time, we have translated into Spanish for our Latin American sisters. And what I've said is now we have to take this Spanish and translate it into English and use it here in these United States.
So again, so many interesting things here. The loss that you talked about between 2009 and 2019, why why such a loss?
I think there are multiple factors, and that is that were not as intensive with the educational campaign. There used to be so many red dress events, and we are now once again beginning to step them up. But we have to reach a more widespread audience. We have to reach the younger women who were never addressed in prior campaigns. We have to have programs that address racial and ethnic minorities so that communities of faith are really important in terms of their ministry outreach to women. And what we are learning is we have to address the women where they are. And there was a fascinating study done in men that was reported a few years back. It was called the barbershop study. And what was done was that in the barbershops that were frequented by Black men, they had a pharmacist. And the pharmacist there discussed with the men while they were there the importance of blood pressure control, the importance of taking medicines, and of taking medicines regularly. And what was seen is that just that barbershop discussion increased adherence to medication and improved outcomes. Where are comparable programs in women's nail salons where they spend a lot of time, in the women's hairdressers? This is an opportunity to go to women where they are, to get the people involved who are trusted sources and do education. But women will not come to us for education, so we have to go where the women are. And I think prime targets that remain unaddressed in the community are the nail salons and the hairdressers.
And another follow-up question I have has to do with, you mentioned this a number of times, how um, issues of race, socioeconomic status, access, how those intersect with the underdiagnosis of heart disease in women. Can you say can you say more about that? And you're also talking about your concern that with the current administration that there might not be as much focus in those areas.
Well, what we realize actually, both for women and for men, is that your zip code may be indicative of your heart disease risk. And we see that in most major cities. And that really addresses the social determinants of health. It addresses housing, it addresses access to food, access to medical care, air pollution, uh, smoking behaviors. All of the social determinants of health really are encompassed in the D zip code designation. So that we're seeing within most of our major cities the equivalent of a third world country.
And can we also go back to what you were saying earlier about um, wondering if certain requirements with regard to um, research will be perceived as DEI and therefore unacceptable by the current administration. Um, can you speak? Can you say a little bit more about that?
I think there is a widespread concern among research scientists that if we do clinical studies, we have to involve a representative population. The research studies, in order for their outcomes to be applied to a representative population, has to encompass that population. Now, how we do that with a restricted lexicon that we have today is going to be challenging. But if we are investing money in research and don't have as research participants representative populations, then we selectively disadvantage those populations.
Yeah. Really. Um, what do you hope women's cardiovascular research will look like in 20 years?
I would like to see health equity so that and that doesn't mean that the treatments are the same, because that's equal, that's not equity, but that the outcomes are the same. And this involves equal access, equal participation, equal benefit. And those are the areas that have to be examined very, very carefully. And just saying we're going to do things equally does not necessarily provide equity.
And how how do you think we get to health equity? I guess especially in the current climate that we're in.
Well, the challenge is for our unrepresented or underrepresented minorities, for our impoverished populations. And if there is limitation of health access, which is what we're seeing right now, that is the first step to inequality in outcomes and equity in outcomes. Because inequity in access to medical care obviously will not produce good results. So much of this is not in the strictly medical sphere, it's in public policy. But it is incumbent on health professionals to become involved in the political scene that relates to healthcare policy, because we can be the strongest advocates for our patients. Our professional organizations can be the strongest advocates for our patients. And that is happening among many of the cardiology professional societies. That involves not only physicians, but nurses, nurse practitioners, physician assistants, and the whole sphere of individuals who care for patients with heart disease.
Um, a related question to some of what you've been talking about is when you were back in the 1960s and 70s, coming to understand that heart disease was presenting differently in women than in men, and that there wasn't any literature on this. Um, you in the 1960s and 70s, what might you be surprised by today with regard to both research and treatment of cardiovascular disease in women?
The research is progressing, and we're seeing more and more women in clinical trials. But what we're seeing, sadly, is that it is the middle-aged women who have good representation in the trials. The young women are substantially underrepresented, and the elderly women substantially underrepresented. And in the elderly population, women predominate, so that they should be the ones that we certainly study as we study whatever the disease is at elderly age. What I'm surprised at is that very, very many people who run trials have yet to learn strategies for recruiting women. and have to design, and there are systems now of designing trials that encourage the recruitment of women. Uh, Many of them are the decentralization of trials so that the study sites are nearer to the women. They don't have to travel to a major medical center. There are so many wearables that can transmit data so that we don't require people to come for visits. There are so many ways that we can use telehealth in the conduct of the trials that will encourage the participation of rural women. And as you know, rurality is an indicator of risk simply because of the limited health infrastructure in rural areas. So there are trial designs that can encourage the participation of women. And we really have to encourage clinicians to talk to their women patients about clinical trials as they talk to their male patients.
Again, what's stopping that in 2025? What do you think is stopping clinicians from talking to their women patients about clinical trials in, in heart disease?
I expect that they realize that so many women patients have challenges, either care challenges for children or for older individuals or work-life challenges. And the question is adding something else, but not realizing that women really are eager to participate. And if the format of the trial will encourage them to participate, they will do that. I have had very many women involved in trials that I have either led or participated in. And some of these were long trials, not just 6 months or 12 months, but some of these were 7, 8, 9 year long trials. And to a person, the women who did participate said, I want to have for my daughters and granddaughters the information that's available for my sons and my grandsons. And women do want to participate and to give back.
Mhm. And a question for you about clinicians, about physicians. This isn't about research, but how can we better train physicians of all gender identities today to recognize sex-specific um, presentations of cardiovascular disease? And how do you think we're doing with that today?
Well, it is in the clinical practice guidelines. I had the privilege of representing North America on the European guideline on acute coronary syndrome. And we have a specific picture and section on presenting symptoms of acute coronary syndrome for women and for men, with pictures and with items. So we are beginning to get this into the scientific literature. And I expect more people recognize it. Perhaps the recognition is less in the acute care setting than it is for clinicians who care for women patients routinely. But we are beginning to make progress in that area.
Okay. Okay. Um, a few minutes ago, you mentioned um, that elderly women are often left out of, you said it, I think you were talking about the research areas. Can we talk about your work now in geriatric cardiology? I've read about your extensive work in that field. Can you talk about how you developed your interest in that area?
Well, I expect it's almost an extension of what I was doing with the heart disease in women, because as we've just discussed, women predominate in the elderly population.
Mhm.
And even where they don't predominate, they are often the major caregivers or the decision makers about care for their household.
Mhm.
So that as our population ages, and as we have in the US far better insurance coverage for our elderly patients because of Medicare over age 65, there is better access to care over age 65 than there is below. And even if Medicare doesn't cover many things, it does not cover medications unless there is supplemental insurance. It does cover much of the access to care. And we have the ability to get data that give us sex differences from the Medicare database, which is excellent and extensive. And looking at the Medicare database, we see that the women don't do as well as the men. And this studies of the Medicare database tells us a bit about access to care and whether older patients, comparing Medicare from non-Medicare patients, are offered as many interventional options. Probably one of the major advances that we're making in geriatric care is something called PPO, patient preferred outcomes. And patient preferred outcomes are often not the endpoints that are looked at in clinical practice guidelines that look at morbidity and mortality. And in all of the studies that have examined patient preferred outcomes, rising to the top are independence, mobility, lack of hospitalization, mentation. So if you ask patients what they want, those are some of the outcomes that we have to begin to look at in our clinical trials in the older patients to see if they're meeting what they want. And very often, when I'll recommend an interventional approach to my elderly patients, I will talk not about the mortality benefit because that is less of concern to very many patients, but will this keep me out of the hospital? Will the symptoms decrease? Will it allow me mobility? Will it allow me to do what I want to do in my daily life? So quality of life issues become really important at elderly age. And we have to begin to recognize this as we design trials. Certainly, they should not be the primary outcome of trials, but we can easily collect those data as secondary outcomes without too much participant burden.
Um, so I've read that, you served as president of the Society of Geriatric Cardiology, that you were editor-in-chief of the American Journal of Geriatric Cardiology for, I believe it was over 15 years. What are the things you're proudest of in terms of your contributions to this field?
Well, I expect that I have helped lead the recognition of geriatric cardiology as a specialty, and I've been an advocate for research in geriatric populations. I've participated in guidelines addressing specific subsets of patients, and I always see that the geriatric patients are at least addressed in those guidelines. And there is a online textbook in progress from the European Society of Cardiology, and I've been invited to edit the geriatric cardiology section and have recruited an outstanding cast of characters to write the chapters for me. And most of those chapters will be due sometime next year, and hopefully they'll be a contemporary publication because the last issue of that textbook, I think, was 2013. So quite outdated. And that will provide guidance for the clinical community.
Fantastic. Uh, from from someone who's not an MD, that the idea that geriatric cardiology would not be a focus seems crazy. Um, I don't. I'm still trying to understand how that was ever the case. Why there wasn't a focus on an older population with regard to cardiology?
Well, the patients stay with their clinicians, and most of the physicians will say, I treat geriatric patients. But the question is, should the treatments be the same as they are for younger individuals? And there's so much of an emphasis that is less on chronologic age and more on biologic age. So that there are many determinants of geriatric health that we don't look at as much. Certainly the 5 M's, the mentation, the mobility, etc. And these are really important to the geriatric patient, so that doing the same care year after year is probably not optimal care at age 80 as it was at age 60.
Okay. And can you just say, I mean, I've read about this, but just so that we have this here, the difference between chronological versus biological age?
Chronologic age is obvious. Biologic age really relates to a number of features that relate to systemic health, and it involves all of the organ systems.
Mhm.
And we really don't have a single measure of biologic age. And a number of years ago, I wrote a paper for one of the journals called Do We Need an APGAR Score for Older Adults? And you know, when the babies are born, there are a few things that people look at immediately and they give an APGAR score.
Yeah.
Well, I think when an older patient walks into a clinical setting, there are a number of things that can be looked at. Are they walking independently? Do they respond to questions? Can they sit and stand? What are other aspects of mentation? So there are very few simple things that I would hope that someone would develop a score that could be used perhaps every year and might be fairly good surrogates for biologic age.
That's fantastic. Um, so with in geriatric cardiology, in addition to someone developing an APGAR score for older adults, or the equivalent for older adults, what changes do you hope to see in the coming years in the field of geriatric cardiology?
Again, I want to see some of the results of clinical trials in the elderly incorporating those endpoints that are valued by older patients. I hope to see more clinical trials involving elderly patients, because if you look at some of the clinical recommendations, they say this and this is recommended to age 80. The reason is that there were no patients over age 80 included in the trials. Well, if I have medications that are working in an 80-year-old patient, I'm not going to stop them just because they turned 80. But I really would like more data to know if they are equally effective or possibly if they're more risky. So
Yeah.
we are seeing so many more of these patients. Probably the major interest in the elderly population came with the development of the catheter aortic valve replacement, because aortic stenosis, narrowing of the aortic valve, is a disease that predominates at elderly age. It progresses more rapidly at elderly age. And early on, the only option was surgery, which was high risk and limited benefit. And the availability of this transcatheter procedure, where patients came into the hospital, could not walk without symptoms from their room to the nurse's station, and 2 days later were ready to go home without symptoms. And some of them saying, why do I have to go to the emergency room in a wheelchair to leave the hospital? It was really dramatic, but it taught us, the interventional cardiologists, taught us so many things that we have to look at elderly age. And they determined that frailty was one of the features that predicted an adverse outcome. And there are a number of indices of frailty, and the Frieden index is probably the one that's most commonly used. But the question is there something that we might be able to do to older adults to precondition them? Or is it too late? Or is it that for older adults, does maintenance of mobility and maintenance of body strength and muscle tone, is that going to be important for their total health? But everyone now is looking at frailty as a variable. And I'd like to see more research done into the prevention of frailty in older adults. Is physical activity an important feature? How does this apply to nursing home patients as compared to patients living independently? Are there medications? Does diet make a difference? There are 15 variables I can list, but there are people who are studying it, and nothing really that exciting has come out yet, save for the fact that maintenance of physical activity is really important. So that's an educational component. And maintenance of involvement seems important for mental acuity, interaction with individuals, not the situation that encourages loneliness or lack of interaction. But these are soft endpoints that need to be studied very, very carefully.
Thank you. Thank you. Uh, I want to turn to a different area that we talked about quite a bit when in your first interview session, and that is cardiac rehabilitation. In our last interview, you explained that you helped build the field of cardiac rehabilitation from the ground up. You talked about setting up an ambulatory exercise program at Grady Memorial Hospital. And I wanted to find out when did you do that, setting up the ambulatory exercise program there, which we had talked about before?
It was really in the early 1960s.
Okay.
It was a federal grant. At that time, it was from HHS, the Department of Health and Human Services.
Yes.
And actually, it was the first federal grant at Grady Hospital. And it was deferred for a little bit of time until Grady integrated, because this coincided with the civil rights and no federal funding was given to segregated institutions. So this was a long-term grant. It was about 5 years, and then it was continued for a while. And there were so many things that enabled it happening. I had been exposed to the concept of moving cardiac patients around when I was a medical student, and Sam Levine developed the chair treatment. And I really was very impressed with it. And I didn't see much reason for the extensive immobilization of coronary patients. And I think, as we discussed, the basis for that immobilization was autopsy studies that showed that patients who died from a coronary event, that their hearts didn't heal until about 6 months. But those are the patients who died, and I challenged whether that applied to the patients who survived. And this coincided with the development of coronary care units, so that we now had hardwired monitors where we could look at heart rhythm and see that physical activity would not put patients at risk of abnormal rhythms. So we developed a then 21-step program, and we worked with physical therapy and occupational therapy, a large number of specialties with the exercise physiologists, and developed a physical activity program that first was simply walking around the bed, and then after a while, just walking. And we sent our patients home at 21 days, hence the 21-day step. And I think, as I've told you before, we had no serious problems with our patients. We originally had tried to randomize patients so that one half of the patients would have early ambulation, the other half would not. But our coronary care units were interesting facilities. They were 8-bed units with 4 beds on one side and 4 beds on the other. And we thought that we could randomize them, one side yes and one side no. But what the nurses told us very rapidly is that the patients randomized to bed rest saw what was happening, that the patients who were moving around and against medical advice, they would just mimic what those patients were doing. So just for physical constraints, we couldn't do it. But when I presented my data at the scientific meetings, and they were really relatively powerful data showing no risk and showing that patients could return home safely without risk, the questions were less about the science and more about how much medical malpractice insurance I was carrying.
I remember you say that. So how long did it take for cardiac rehabilitation in this way to become the standard of care?
The people who were advocates, and I was one of the founders of the Society of Cardiac Rehabilitation, now with a new and much more elaborate name. But this was a very attractive idea, and it took a while for early ambulation in the hospital to develop, simply because people were unsure of its safety. I think we demonstrated its safety, but people were unsure, and that took more time. But you have to realize what the rehabilitation model was in Europe, where cardiac rehabilitation antedated that in the US by decades.
You had
And
mentioned that.
in Europe, this was residential rehabilitation, where patients were sent to, for example, a castle in the Black Forest for a number of months before they returned to their community and were then in local rehabilitation programs called sports programs. But that was certainly not a feasible model in the US. And a number of us in the US said we have to do this on an ambulatory basis. And ours was one of the earliest cardiac rehabilitation programs in the country. And because everyone was hesitant about it, we did something that I regret. We didn't enroll the patients in ambulatory rehabilitation for about 6 weeks. So they went home, they were given instructions to walk around the house, etc. But I think we lost 6 weeks, and we lost a number of patients to care. Now we send patients from the hospital to rehab. And again, there was this antedated monitoring. And we used a gym, we used mats, and we learned to use children's equipment because using adult exercise equipment was beyond the capabilities of many of these older patients. So we used lightweight children's balls and bats and what have you. We did relay races. We had them play ball in a circle. We had them walk. We had them do exercises to music. And they would walk by the ECG machine, put their hands on so we could record their heart rate response. There was no monitoring available. What happened, I think, was not a good service to cardiac rehabilitation because as the monitoring became available, it became an industry. The approval was for 36 sessions, and the model became one patient, one nurse, one bicycle, and it was costly. And patients had to go to a center, which limited access, and there was really no self-determination. So we really didn't know what happened after the patients completed their 36 sessions, but every one of the studies was positive in terms of improving exercise tolerance, There were very good educational sessions that were really helpful about medication taking, about risk reduction, and so forth. So the educational sessions were really important, and they were reimbursed. But the long-term adherence to physical activity was less than optimal. And many of us talked about the possibility of hybrid sessions. The British were among the earliest to do rehabilitation at a distance. And again, as the technology improved, some of these were videos. Now we can do it by using any one of the hybrid techniques. Now we can transmit laboratory and physiologic responses, et cetera. And particularly during COVID, hybrid rehabilitation took off. And programs were developed that were not equipment-based, although some of them were. Some patients could afford exercise bicycles or treadmills. But now I think there is a major interest, and there are more than a few papers showing that non-supervised rehabilitation for selected patients is safe. In the guidelines, it's now recommended for patients who don't have access to rehabilitation centers. And there is evidence that patients who do home rehabilitation are more likely to stay with an exercise program after the formal 36 sessions are over. And that is influenced by a lot of data from the United Kingdom, because this is self-determination of exercise, and patients will continue with it. There are a lot more studies that are needed. If I had the ability to wave my magic wand, what I would do is I'd have 1 or 2 sessions supervised at the hospital or at a medical care center, so that patients would be comfortable and feel safe with exercising. And people who had never exercised would be shown how to exercise, and then have them go to home exercise. And right now, we are trying to set up a program of this at Grady, because the supervised exercise programs have declined substantially because they're not financially viable. If there are the reimbursement under Medicare and Medicaid is so low that if there are not a substantial number of privately insured patients, the center is not viable. So we have to get this where it is viable, and the hybrid programs are where this may happen.
Okay, very interesting. Is there anything else you'd like to say about the state of cardiac rehabilitation today, or about your involvement in cardiac rehabilitation?
I think it's evolving right now,
Mhm.
and its evolution is really guided by technology. And the better the technology, the greater the accessibility. Certainly, it has the potential to bring cardiac rehabilitation to patients who are at a distance from centers, which are
Yep.
usually in major medical centers. The patient interest is really great. And there are many, many hospitals now where patients who have an intervention or bypass surgery or acute coronary event, where this is part of the discharge planning. Some hospitals automatically refer to cardiac rehabilitation, but that really is more exclusively hospitals for privately insured patients, because
Okay.
the rehabilitation centers that take uninsured patients are few and far between. Those who take Medicare and Medicaid have a limited enrollment of those patients.
Okay, thank you. I want to turn now to something that you were talking about earlier today, and also somewhat in the last session as well, and that is your leadership. Um, you said both last time and today that you have a different leadership style than most people do, that most people lead from the top down, and you tend to lead from the bottom up, and that you get people enrolled in your vision, and then once they're enrolled, they take off and go in different directions that interest them. Um, I want to hear much more about that. Have you always had that leadership style? How did you develop it? I want to hear more.
Well, I went to a girls' high school and a women's college,
Hmm.
so that I was very comfortable because there was not the competitiveness of the girls versus the boys.
Hmm.
And I went to schools that focused on developing women leaders.
Hmm.
So that in high school, I was involved with a number of clubs and a number of groups, and I usually ended up in a leadership position. And in college, I was involved very much with student government and student activities and ended up in a leadership position. And same with my sorority. But the I don't know whether it was my assurance that I could do it as well or better than the other people, but I always seemed to end up in leadership positions. Uh, when I came to Atlanta, I joined a number of organizations, and I quickly ended up as the woman president or the first woman president if it was a non women's organization. And I think I'm very comfortable with myself. I'm comfortable with my skills. Early on, I learned some of the basics like Robert's Rules of Order and how you run a meeting. And because I assumed that most people who were involved in organizations and committees could read, as I led, one of the things that I did was to say, how many meetings can we avoid if we send out materials ahead of time and people respond so that uh, I think people liked the leadership style that gave them autonomy. And that led to my being the first woman president of the Georgia Heart Association and the first woman president of the Georgia chapter of the American College of Cardiology. And as I told my colleagues at the meeting last November, I was president of the Georgia chapter of the American College of Cardiology from 1983 to 1986. I served 2 terms. It took them 40 years to get another woman president. I said, so when we look at DEI, we have to look at it within our own organization and say, what is it that we have to do to encourage women to be in leadership positions?
Uh, so actually, I want to ask you that since you're mentioning it, what do you think we need to do to encourage women to be in leadership positions, whether at the Georgia chapter of the American College of Cardiology or elsewhere?
I think first is mentorship, and secondly is sponsorship. And as I work with young women, both in training and young faculty members, mentor, and this is both men and women, mentoring and then sponsoring. I want to see if there is a position available. I think of the people that I know, both women and men, and I'm very active in nominating them. When there are awards available, I want to see very carefully that the women and men that I work with are nominated for those awards and that I get someone else to co-nominate with me. Or if I've sponsored A and I think B is a good candidate, I'll call someone else to say, would you sponsor B? I sponsored A. So it's an active way of encouraging leadership. And I've encouraged, again, my young trainees and junior faculty to become involved in the professional organizations. And as I see the leaders, both of the American Heart Association and the American College of Cardiology, I can smile a very big smile and say that very many of these are men and women that I have either mentored or sponsored.
Wonderful. Uh, Can you just explain briefly the difference between mentorship and sponsorship?
Well, sponsorship is a much more active process. It means essentially advocating for someone to be in a position or to have an award or what have you. That's a very active process. Mentoring is a two-way street. And typically it's the mentee who will indicate an interest, or it is the ability to get a junior person in a position. For example, I'm asked to write a large number of papers or articles. If it's something that's immediate and I have to do it within the next several months, it's faster to do it alone. But if it's something that has a little bit of lead time where I have the opportunity to mentor, I will get a trainee or a junior faculty member, often to become first author on a manuscript, where I have the ability to teach them how to write, to review their writing, and then to give them a first author paper. And it really is a very active mentorship in terms of writing. And more recently, I was asked to do something very extensive for a book that is coming out on women in cardiology. And it's something that I did not have the bandwidth to do as first author. So I went to one of my more senior colleagues, whom I knew was a good author, and where I knew a first author chapter would be an important component of her promotion package, asked her to do it, and we picked another junior faculty member, and the three of us did that chapter together. And it was a learning curve for everyone. It was fun because we cooperated. It was very hard work because we were in three separate facilities, but we came out with a chapter in a book that addresses women in disease. And we did the heart disease chapter. And looking back on it as we read page proof, I said to my author number one and author number two, because I'm the last author on the manuscript, I said, this is a good chapter.
That's really wonderful. Sounds like lucky are the people in Dr. Wenger's orbit, is what I'm hearing. It is sponsoring, and maybe in particular mentoring, does it look different when you're mentoring women colleagues as compared to men colleagues? Does that end up looking different in any way?
Not really, because remember, the mentee usually reaches out to you. And very often I'll be running a conference and someone will present a case at the conference, man or woman, very often a resident, not even a cardiology trainee, and say, I'm interested in cardiology, what can I do? And then it's a combination of mentorship and scholarship. If it's been a fabulous conference, I'll say, why don't you consider submitting this for presentation at this meeting or at that meeting? Or if it's not, are you writing this up? And who is your faculty advisor? Who is the clinician on the case? And are you doing it? So it's a combination of mentoring and sponsoring. And very often these people will come back again.
Sure they do.
For a revisit.
I'm not surprised to hear that. You've given some examples of your approach to leadership. I know that over the decades you've served in so many leadership roles. For example, within the American Heart Association, the American College of Cardiology, National Institutes of Health, task forces, World Health Organization committees. Is there any one of those that you want to pick, or others, and talk a little bit more about how your leadership from the bottom up worked?
Well, I think by the time you become president of an organization, your leadership from the bottom up is gone, because your responsibility is to move that organization forward during the tenure of your term. It's when you come up with something new, a new approach, a new concept, that you really have to do it. And I think the farther you are on the accomplishment scale, the easier it becomes to float a new idea and see if it's going to launch. And there often are more people who are ready to listen. And I think that this is something that has happened with the hybrid cardiac rehabilitation. I've earned my spurs in cardiac rehabilitation. And when I talk about approaches to hybrid, there are people who are listening and who are really growing that area. And the Million Hearts program has been very, very active in encouraging hybrid cardiac rehabilitation. And now, again, with the contemporary funding of so many of these programs, I think many of the interesting interventions have been paused, but I hope that pause won't be for long.
Me too. Um, I know another place you've played a leadership role is in guideline development. Can you talk a little bit about that for someone who isn't familiar with guideline development? How does that work, and what kind of role have you played?
Well, the organization determines that there is need for a clinical practice guideline.
Mhm.
And then there is typically a writing committee group that looks for leaders who are willing to put in the time and the effort required to make a good guideline. And they ask you to participate either as the chair or co-chair of a guideline or as a writing committee member. And each organization has its own way of writing guidelines. I've been honored to have been asked by the US groups to write guidelines for women, to write guidelines for acute coronary syndromes, to write other guidelines. And most recently, I was asked to be the North American author on the European Society of Cardiology acute coronary syndrome guideline. Now, that guideline was during COVID, so much of it was on Zoom, but a few of the meetings were in person. But the meetings on Zoom were interesting because the ESC is based in Paris, and 9 a.m. Paris time is the wee hours of the morning in Atlanta time. So the monthly meetings were a little bit of a challenge to my next day. But I worked with very exciting people, people who learned how to do things at a distance. And I made many valued colleagues working with the European guideline.
Okay. And here you're talking, right, about not only have you had a national impact, but you've also had an incredible um, global impact. Um, Looking back, where do you feel you've had the greatest impact on public policy or on policy or public health, nationally, globally, locally?
Well, again, if there is an area in medicine that requires attention to public policy, then you become an advocate. And all of the professional societies have very large advocacy groups and public policy groups. And some of it involves as little as in Atlanta, my traveling a mile to the Gold Dome, which is the Georgia uh, House of Representatives and Senate, and some of it involves going to Washington for an advocacy meeting. So I've had the opportunity to testify before congressional committees, to meet with staffers of our elected representatives, because that's where public policy happens. And some of it has been slow but important. Uh, some of it has been very satisfying. In Georgia, we realized that maternal mortality was really a very serious problem. And I made many trips to the Gold Dome to talk to my elected representatives, but most importantly, to talk to their very bright young men and women staff members who read the bills, who help write the bills, who talk to the elected representatives. And the Georgia, or actually Georgia Medicaid for women covers them during pregnancy and until the 6 weeks postpartum. And of course, it's at that visit that very many of the serious problems become identified, but their insurance then lapses. And our efforts, a large number of us going down to the Gold Dome multiple times, we now have 12 months of insurance for women after they deliver their baby. So we have the opportunity to do a huge amount in terms of education, in terms of intervention, in terms of care. And the whole area of maternal mortality has gotten a great deal of attention nationwide, and fascinating things are happening. Let me give you one example that I find fascinating. We looked at the distance of women who give birth from where they live to their birthing hospital. And in urban centers, it's 5 or 10 miles. In some of the rural centers, it can be 75 miles. Now, they're not going to show up for their postpartum visit to address any of the problems. And one of the research studies that's underway, and it's the kind of thing that I hope will get funded because I think it offers a great deal of promise, is the question of the pediatric visit. If you have in the pediatric office where the women are going to take their babies, if you have an advanced practice nurse who provides follow-up care for the mother during the baby's well-baby visit, what will that do to improve maternal health? It's a study that's in progress. I think the promise of it is enormous. It's going to require resources. But there are programs like this that are being established, that are imaginative, that are creative, and that are designed to improve outcomes for women.
Wonderful. Thank you for explaining that. I want to turn to something somewhat different. In our first interview, we talked about what it was like for you to be a young Northeastern Jewish woman cardiologist when you first arrived at Grady. I would like to hear more about how being a woman physician has affected how others have perceived you since that time, since that early time. And also about how being a woman physician has affected how you've operated in the world. But maybe let's talk about how being a woman physician has affected how others have perceived you over the years, and how much has that changed, that kind of thing. Again, you talked about it from those very early, you were talking about what it was like in those very early years.
Well, this really is inextricably intertwined with the civil rights movement, because I had never lived in a segregated society.
And
I
you had
was
talked about that.
educated and trained in New York and Boston, and that was not part of my background.
Mhm.
And I expect I inadvertently became involved in the civil rights movement because, as head of the clinic at Grady, we had the system where patients were called into their appointments on a PA system. The white patients were called Mr. or Mrs. The Black patients were called by their first name. And that was unacceptable to me.
You had talked about this, yes.
And I changed that in my clinic, got reported to administration,
Right.
but it continued in my clinic. And through that, I had the luxury of meeting some of the leaders in the civil rights movement who heard of what I was doing at Grady. And I think that because I cut my teeth on this very overarching problem, the fact that I was that funny talking lady doctor, that was less important than this contribution. And I think I earned my spurs there. So that perhaps because I did challenge an established norm and succeed, I was accepted as a leader. No one challenged really the things that I did. I still remain that funny talking lady doctor, but my northern speech slowed a little bit, softened a little bit, and I expect that it was my leadership in this area that encouraged me to do other things in the clinic that were not civil rights related, but that were patient related, and establish programs in the clinic. And there was no challenge to them because they had never been done before. No one could tell me, you can't do this because, but they were new, and I established a variety of patient education and training programs, et cetera. And those, I expect, were leadership roles. And the nurses in the clinic were so excited at what they were able to do with patients. And because they were the people who were there, I gave them responsibility. I delegated to nurses who are not baccalaureate trained nurses, who are nursing school trained nurses, responsibility for an anticoagulant clinic, responsibility for running rheumatic fever prophylaxis out of a green card box. They were the ones who called the patients who kept it. And they did it beautifully. And many of the nurses stayed with me for decades because they were doing things that expanded their horizon and that improved outcomes for patients, and were really very excited. But I think this was leadership by example, by giving people a structure within which they could function, and they did beautifully. And this is the reason that if something came up in terms of policy and what have you, I was one of the people that was called in to participate. And that was a luxury. I think some of that got me elected to the University Faculty Council and to the University Senate. And I had the opportunity there to, I think, make important contributions because I was a member and then subsequently chair of the Faculty Life Course Committee.
I remember you saying that.
And we initiated a discussion about maternity leave, which had never been talked about, and got that into the Gray Book. I think I told you before that it was my committee. That was the founding committee for the Emeritus College of the university, which is
Yes.
now a wonderful organization for people who have retired from practice but still want a connection to academia. So we did a number of very adventurous things there. Again, because the people there were all elected to leadership positions, they were very responsive to new ideas. The faculty council was a very select group of elected leaders. And as such, a number of exciting proposals over the years have come and still come from faculty council.
Sounds very satisfying, and sounds like you really made a difference there.
Yes, yes.
Um, what about, I mean, you were talking about both today and in the first interview session about cutting your teeth during the civil rights movement. What about after that time, um, 70s, 80s, 90s? You've been your whole career at Grady and Emory. Um, you know, to what extent do you think being a woman physician affected how others perceived you?
I think as more and more women came into medicine, the designation of lady doctor no longer identified me. And I think I had established my leadership roles so well that they just sort of came with the title. And actually, when there are some problems involved, I'm still invited to sit on some committees or to say, are you interested in being involved in this? And I can be selective.
That's great. Um, uh, I want to turn to more about your personal life. We talked some about this in the first session, marriage, family, community. You talked about meeting and marrying your husband, Dr. Julius Wenger, gastroenterologist, and moving down together to Atlanta. You talked a little bit about raising three daughters, um, and uh, and balancing some of that. I'd be interested to hear um, more um, about the values that were most important to you and your husband in raising your daughters, who I know you said were born like in the late 50s through the early 60s. You said there are 5 years between them. What were the values that were most important to the two of you in raising your daughters?
Well, again, you have to remember that we raised our daughters in a segregated society, which was not according to the values that we had had as young adults, both in our former lives and in our Atlanta life. So we were very, very careful to emphasize to them that people were equal and that they had equal respect for our employees or people we worked with who were African American and who were white. And we always were respectful to our employees who were Black. Uh, and the children were never allowed to take advantage of them. So they were part of the family. And I think when my children started school, there was the whole issue of would the public schools close in Atlanta? And that was the response to integration. And we were very active, as were so many of our friends, in the hope to help our public education to keep the public schools open. And my children started in public school. And unfortunately, what the Atlanta solution to integration was busing. So Atlanta is such a large city and such a divided city that children were bused into the white schools on the north side of town. And we were with that, although it created tremendous discipline. You take any child of any age and put them on a bus for 45 minutes in the morning, and they're going to have behavior problems when they arrive in school. So we accepted that for a little while as necessity. But the day that they said they were going to take our children and bus them to the south side of town, I said, I just cannot allow my children to become part of that experiment. And fortunately, they tested well and they all tested into a private school. And that was one of the decisions that my husband and I made. And we still continue to support public education, and we saw the schools integrate gradually and semi-successfully. If the same amount of money had been spent on education as had been spent on busing, we would probably have a fabulous public education system in Atlanta, which is still lacking.
Yeah. Um, Careers. You and your husband both have big careers, right? I know you said your husband was the one who got the job first in Atlanta, and that was the reason the two of you went to Atlanta initially. How did the two of you make decisions about careers when you had, you know, three daughters and I know also a very active community life, which you talked a little bit about last time. I want to get into that more. How did you make decisions about your careers? You clearly made a decision to stay in Atlanta, but how did you do that?
Well, we always schedule at work, and we're expert at scheduling at work. And what we became was expert at scheduling at home. So that when we did our on-call schedule for the next month, the two of us were never on call the same night.
Mm-hmm.
Uh, so that there was always someone home with the children if we were called in. Uh, we scheduled our vacations as precisely as we scheduled our conferences, so that we could either get home to New York to visit with family, or we could travel. And both my husband and I were involved in professional organizations, which meant travel. And we saw that we were not out of town at the same time. So there's always someone who was at home. But because we did a great deal of travel, we often had the opportunity either to travel together if
Mm-hmm.
we, or to take one of the children. If we couldn't travel together to a special place, we would try to take one of the children in rotation to A, B, and C, so that by the time they were in secondary school, they had almost circled the globe. And I think they were exposed to travel very early. They traveled very well. They were comfortable meeting strangers in cities where my husband or I were lecturing. There was always someone who would take them around and show them the city, introduce them to their children. And they became great travelers, traveled a great deal on their own subsequently, and even subsequently traveled with their children.
It's really cool. Uh, I have read that two of your daughters are physicians and one is an historian. Um, can you say a little bit about um, each of them?
Yeah, my oldest daughter is an ophthalmologist and was at University of Alabama, Birmingham. My second daughter does obstetrics in New York City, and my youngest daughter, again, the one who strayed from the medicine pathway of the rest of her family, was an historian who spent much of her career as chair of history at the University of Pennsylvania. More recently, she has been dean of the graduate school at
Uh,
the University of Pennsylvania.
and uh, and what's your sense of the challenges they've faced as women professionals, and in two cases as women physicians, as compared to the challenges that you faced?
Very different, because it was a very different era, and the challenges of child rearing were much more difficult for them than for me, simply because it was a different time and different availability of skilled childcare help. But you have to remember that one of my father's sisters was a surgeon in Europe. So when my daughters are asked, what's it like to be a woman physician, they'll say that they were third generation.
Right. Amazing. Yes. Um, I know, and again, we talked about this a little bit last time, that you've been deeply involved in the Jewish community in Atlanta. Um, can you say more about the kinds of things you've been involved with? You mentioned Hadassah, your synagogue. You said that when you first moved to Atlanta, quickly joined a synagogue. Can you talk a little bit more about the things you've been involved in and what that involvement means to you and has meant to you?
Well, going to a strange city, my mother's orientation to me
Right.
was that you join a synagogue and you
Yeah.
join Hadassah,
Yeah.
which I did quite promptly. I became involved in my synagogue, but my husband was much more involved.
I
He was
remember.
involved in the education committee and chaired the education committee for a number of years. My involvement early on was with Hadassah, and I relatively rapidly became president of one of the groups, and a few years later, founded and became president of a second group, the Women's Business and Professional Group, which was an evening group, and the first availability of an evening group for women. And I instituted unusual things in that women's group. First, I said, in order to join it, you have to be a life member, so that if all the members were life members, we never had any problem with membership. We never had any problem with re-enrollment. So that was a chore that the chapter never had. And we could focus on information and education. And because we were all business and professional women, I did a great deal by the brand new advent of email. So instead of having committee meetings and board meetings, et cetera, we had meetings that were conducted by the email, and the business part of it became less of a chore. And we did do some fundraising, but we didn't have to do membership. And our main focus was education. And we selected the educational programs that we wanted, and our meetings were primarily educational. So it was a very different departure from some of the other groups that I had chaired. And then I found out that I was being recruited to other groups. There was a fascinating group in Atlanta that was the Jewish Children's Service that had run the Atlanta Orphan Home. And by the time I became president of the group, we only had one remaining orphan who was still in the age where we were supporting and supervising. So that became less, and we essentially pivoted to doing something different and became the Jewish Educational Loan Fund. And what we did was to try to raise money to provide no interest loans to Jewish students once their Pell Grants and all of their other federal funding was no longer available. It was a Southeastern group, but Atlanta was the focus for it. And I remember during the years that I was president, when we gave something like several $100,000 worth of loans, and we thought that was unbelievable. I recently attended a JELF meeting where the group has grown to where we gave over $2 million in loans this year. They are non-interest loans, and we still retain our 98 to 90% payback of those loans. So the money goes back in to reinforce. And we now have a number of previous JELF recipients who are leaders in the organization. So that's an amazing success story that I'm really proud of having been a part of. And then we had a few groups that transitioned in and out, but that I had the privilege to be president of. And this was a program for bar and bat mitzvah students who were mentally challenged. And there was no one within any of the congregations who had enough of these students. And we set up an educational program for them that involved all of the congregations. Uh, Subsequently, as the congregations developed their own programs, that program transitioned out. But that was a bit of negotiating among, I think there were only 6 or 7 congregations at the time, but to get the content that was acceptable to all of them was a bit of a challenge. And I became involved with the Jewish Museum, with the Bremen Museum, which is one of the highlights of Atlanta Jewish cultures. I became involved with some of the lecture series at my synagogue. Let me see what else.
It's a lot.
But I think that the nice thing is that when something comes up in the community, I always get a call to participate. I've done a lot of educational programs, many on women's heart health for the Hadassah chapters and for my synagogue and for the community. And Atlanta has a very active Jewish life. And I think I have gotten so much back from being a participant in that it pales in comparison to what I've given. Just being a part of the community has really enriched my life.
Wonderful. Uh, are there other aspects of your personal life that we haven't touched on that we should?
Well, both my husband and I are music lovers.
I remember that.
And we were members and season subscribers of the Atlanta Symphony beginning in the late 1950s. So we have been significant donors to symphony for over 40 years. And a few years ago, as my involvement with a number of other things diminished, I became involved with the Community Advisory Committee of Symphony. And it has been a just delightful addition to my life because my emphasis there was on patron experience at Symphony. And my emphasis was to try to get young people involved in Symphony. So we developed 2 programs, one for college students, where for a small fee, they become members of this group and can attend any symphony concert where there are unsold seats.
Smart.
And the other one is a program similar to that, but for 25 to 40-year-olds, where again, there's a small fee and they have special concerts to which they get invitations as a cocktail party before or after. They get to meet like-minded people, etc. And it's been going on for long enough that we're beginning to track these programs, and they look as if they're contributing to symphony subscriptions. So this is just trying to get people involved. And of course, as a member of the advisory committee, I have the opportunity to meet many of the performers, to meet our new conductor. Atlanta now is the only major symphony in the US with a woman conductor, and Natalie Stutzman is phenomenal. And we get to interact with a community of musicians that is on a very different level than simply attending concerts. And of course, I'm addicted to the symphony and attend probably 20 plus concerts a year.
Oh, that's amazing. Both the work that you're doing and the opportunities you're getting. That's fantastic. Um, I want to turn now as we're coming closer to the close of your interview, um, to your current work. I realize actually you were just talking about some current work in the area of symphony. But you're sitting in your office talking to me. I'm aware that you are still working. Can you talk about something about your current work, where you're focusing your energies now?
Well, I still value patient care. And there are some patients in clinic that I've taken care of for 3 and 4 decades. So I still meet several clinics a week. Uh, I meet only fellow clinics, which means that the fellows are the primary caregivers, and I just supervise them in their care of patients. So I have the opportunity to multiply what I do in that clinic by 3 or 4 times because I see the patients with each of the fellows. So it's an opportunity to do patient care, but to teach at the same time. And that is really a luxury because that is really apprenticeship. And that's the way people learn cardiology. And they learn, I think, not only how to care for patients, but sort of the principles of caring for patients. And I meet one clinic, which is a preoperative evaluation clinic with the advanced practice providers, where they see patients and I review those with them. So it's a chance for, we now have a group of fantastic advanced practice providers, and we provide supervisory care to them. So this is another group with which we interact, and we've just been very fortunate to attract very, very exciting and competent APPs.
Wonderful.
And
And
then a lot of what I do is committee work and writing. So that the writing, again, as we discussed, some of it I'll do primarily, some of it I'll do with people from away as as practice documents, as commentary documents, and much of it that I'm asked to do, I will select a junior author to lead and follow with them. So I typically have 4 or 5 manuscripts that I'm working on simultaneously at various stages of development, which is
wow,
fun.
amazing. Is that how many you're working on right now?
Right now is a little bit more because we had a pause in November for the American Heart Association scientific sessions, and then another pause for all the holiday celebrations. So now we're getting back to work.
Okay. Um, so what's it like being a physician scientist now as compared to your earlier years? I mean, you sound as busy as ever. Um,
Well, it's as exciting as ever, simply because there are so many new horizons. The things that we talked about earlier, some of the new areas of artificial intelligence in medical care, of all of the new imaging and diagnostic tests. So I feel as if I am both teaching and learning every day. We run a sizable number of conferences. We have 3 conferences a week right here in our cardiology suite for our trainees. I run one monthly conference for the internal medicine residents where they present to me and we discuss cases. And I'll do a number of Zoom calls and lectures for conferences.
Wonderful. Um, so you have received so many prestigious international awards, national awards, local awards, and honors. And there are a number of prestigious awards in your name. It seems like we could spend 4 hours just talking about all of those. Um, are there some of those awards that you've received that are particularly meaningful to you? Again, I know you've received so many.
Probably one of them that actually let me mention 2 of them because they're organizational awards. And the American Heart Association did me the honor a few years ago of naming the Research Goes Red Award for me. And what this is, it's an award that is given annually at the scientific session for the best scientific manuscript related to heart disease in women published in an American Heart Association journal. And this is a selection that's done by a committee and by the journal editors. But what this does is it emphasizes the importance of research in women. And then at the scientific sessions of AHA, I have the responsibility to prepare a 15, 20-minute talk that gives the view from 10,000 feet of the problem, which that awardee is going to discuss. So there's a setting the stage, and then the awardee gives his or her presentation. But I think that has done so much to advance the emphasis on research on heart disease in women that I am so grateful to the Heart Association for naming the award for me. And the other is an organization that I helped found a number of years ago, and that is Women Heart. And Women Heart has named its annual awards the Wenger Awards. I have nothing to do with the selection of the awardees, and there are awards that are given for excellence in medicine, excellence in medical education and public education and advocacy. Very many elected officials have been honored by the group, and it's been my privilege to present some of the awards. But the fact that service to women with heart disease is emphasized by these awards makes my name on them very precious to me.
It's fantastic. A related question is, what do you hope and your legacy is in cardiology, in medicine, in the lives you've touched?
I hope my legacy will be that I have contributed to the healthcare of women, and that I have encouraged other people to do so, that I have encouraged women to become cardiologists, to become leaders in cardiology, to become researchers in cardiology. And I hope that I have taught women researchers and scientists that they are citizens of a community, and that because they are privileged by their education and training, that they have the responsibility to give back to their community in any way that is meaningful to them and meaningful to their community.
Thank you. Slightly different question. When you speak with young women entering medicine today, and I know you do that, what advice do you offer them, or what advice would you like to offer them now? Again, when speaking to young women entering medicine.
Well, again, that they have come so far because they have been selected in a rigorous educational selection process. So they have to value themselves, because if they don't value themselves, no one will value them. And then what they have to do is to search the horizon and to see what gives them satisfaction and where they have the opportunity to contribute. And if that combination is achieved, they will do well.
Sounds like great advice. For any of us, not only those of us not only people in medicine, is there anything that we have not discussed that you feel is important to include in this record of your life in this way?
Well, again, I think this award that got me the interview with you. And I think that the Women's Legacy Foundation that gives the award works very hard to search the medical community. And because of my being a recipient of the award, I've been on the search committee. And I just have enormous respect for the time that everyone devotes to winnowing down a huge list, to a sizable list, to a reasonable list, and then to select the award winner. And I expect that any of us who've been award winners are so grateful for having received the award, but for the time and effort that the committee has put in to searching an appropriate candidate for the award.
Well, Dr. Wenger, I really thank you so much. It has been an extraordinary honor to hear your story. Your contributions to medicine and to the lives of so many people are just incredible. And I'm grateful to you for your time and your generosity in sharing your memories with me and with us. Really, thank you very much.
And I'm grateful to you for your interviewing skills. This has been a pleasure.
Well,
Thank you and have a great day.
you too.
Bye-bye.
Thank you very much. Bye bye.